I think the chat function is not functioning yet, so I'll activate it. Sorry for that for people that are online. Just give me a couple of minutes. And YouTube seems to be working today, which is perfect. Let's go on the chat function because I don't think that you're able to send anything yet. Let me correct that and then we go live. Account. Everyone. Can you check that your chat function is working? Do you want to put something in the chat? So welcome everybody with the first webinar for 2024. This is number 55. And for a change, we thought we'll be looking at benign.
Buenas tardes.
I think you're on English, Ricardo, because
because you have to put it again. Sorry.
Oh.
Okay, no, it's fine.
Okay, perfect. Sorry for that.
Hemos tenido algún problema de comunicación.
Working okay now?
Yeah, you don't listen to me. Yeah, okay.
Okay. So
hay un problema de canales.
I still can hear you quite loud.
Yes, so do I.
Can you do it again? I'm supposed to be in the Spanish channel, but you're listening to me.
Okay, let's manage language interpretation. Apologies for that. Add interpreter. Sorry, that's first time this has happened to us, Ricardo, isn't it?
I know.
Update. Shall we go back to the English channel? And Ricardo, do you want to try to go on the Spanish channel? Yeah. That's perfect. Yeah, that I think. So for people that are listening to the Spanish channel, can you just let me know that you can hear Ricardo? It's great to have you all online. We thought we'll do something a bit different. We haven't addressed any of the benign pathologies in the past webinars. I think it's time to start looking at that. So we're doing rare but benign. I have a co-chair, Irini Pantiora, who's one of the surgeons from Uppsala in Sweden. It's great to have Irini with me. And we have one of the usual suspects always, and the serial offenders is Ricardo Pardo. As Ricardo is translating to Spanish. So if you want to listen to the talks in Spanish, please go to the Spanish channel with Ricardo. We have 4 talks, great speakers. We have Maggie Banis Pulukchovsky from Germany. We have Michael Boland from Ireland. We have Victor Acosta Marine from Venezuela. We have Salim Taye from the UK. And hopefully we will have also Naim Kadoglu, also from the UK, who's going to be in the panelists. Ashutosh Kotari might join us later, but let's start with the talks. The first talk is about nipple adenoma, and it's going to be by Victor Acosta Marin from Venezuela. Victor, the next 10-15 minutes are all yours.
Hello, thank you, Jason. Thank you for this invitation. For me, it's an honor to be here. I would also like to thank, I should start sharing my screen, right?
Yes, please.
Okay, here we go. I would also like to thank Ricardo Pardo for making available these webinars for the Spanish-spoken physicians all around the world. I'm going to stop my video now so it doesn't get in the way of some of the slides. Can you see my presentation now?
I can see the presentation. It's in full mode. Looks perfect.
All right. Without any delay any further this, so let's start talking about nipple adenomas. So nipple adenoma is a very uncommon condition of the breast. It represents a benign proliferative process of the electriferous ducts, as we all know. It's primarily seen in middle-aged women. It's exceptional in men and children. Dr. Rosen, as you can see down there, classical paper of 51 patients reported 2 men who had carcinoma rising in florid papillomatosis. And historically, nipple adenoma has been known by a variety of other names in the literature, including florid papillomatosis of the nipple, as you saw in the previous slide. We could be a while here just naming all of them. The thing is that since the 4th edition of breast tumor classification by the World Health Organization in 2012, the current accepted definition of this lesion was designated as, you can see there, nipple adenoma, ratified in their latest edition, the 5th edition, which you can see in your screen. The earliest published nipple adenoma appeared in a paper by Dr. Cashman Hagensen in 1952 and his colleagues from Presbyterian Hospital in Colombia. Here it was labeled as intraductal papilloma of the lactiferous ducts. But it was until 1955 when it was first described in detail by the pathologist Dr. David Jones from New York State University. Since then, and because of its low incidence, there have been not many papers, I must say, about nipple adenoma, and most of them in case report, or at least 13, 18 cases at the most. And again, the paper by Dr. Rosen with 55 cases, but including other histological subtypes. More recently, Dr. Shiro Roman from Cleveland Clinic published this very nice paper, well-structured, I must say. They review cases from 2003 to 2022. Important fact regarding the data resulting from this paper, look down here. The cases in which no skin was present, no lesion was visible on the slides, or the diagnosis of a nipple adenoma was questionable, were excluded, so we can be 100% sure that all of these cases are indeed nipple adenoma. In this paper, they describe the three major histopathologic growth patterns: adenosis, cell-infiltrative, and papillary light pattern. They also describe in very detail the features of nipple adenoma and noted that more than one histopathologic pattern could coexist in the same lesion. At the end of this description, the authors concluded that with the current available data, the nomenclature and definitions of these patterns are inconsistent and confusing. Hence, there is no data supporting the importance of identifying each subtype, as it doesn't affect the prognosis. You can also see that during median follow-up of 66 months, there was no recurrence. One patient developed invasive ductal carcinoma adjacent to the excision site, but there is still no solid data at this moment that sustain the development of a malignant lesion arising from a nipple adenoma. Another interesting fact from this paper is this: even though the pre-op diagnosis with a core biopsy, a cytology, or even an incisional biopsy should remain the gold standard, look here at the bottom of the table on the right side of the screen, about a quarter of the cohorts were diagnosed with excisional biopsy, showing us that the method for diagnosis could be somehow related to the clinical presentation. It affects part of the nipple, 100% of the nipple. It also affects part of the areola. And look here in the bottom, almost all of the imaging studies resulted in a negative finding. By this clinical presentation, it is often asymptomatic, but it can behave in a locally infiltrative manner. And please hold on to this for the upcoming slides. Hence, patients sometimes present with swelling and complain of itching, also often associated with pain and or erythema. Serosanguinous discharge may lead to a formation of a superficial crust. Now, for its clinical presentation, not necessarily the size matters, or at least not only the size matters, but only where it is located in the nipple. Where is the duct affected by the lesion may affect the clinical scenario. This is the section cut perpendicularly through the nipple. You can see here a very small superficial nipple adenoma, and depending on how it will grow, the outcome of the clinical presentation, as it could grow towards the exit of the nipple, and even though being very small, its clinical presentation may mimic or resemble a very different lesion, let's say a malignant lesion, for example. In the other hand, and again, this is another perpendicular cut of the nipple, so you can have the same size lesion, but deeper in the nipple, finding yourself a Grant zone right here, which is a narrow area of the papillary dermis uninvolved by underlying pathology. Here you can see it. And thus the initial growth actually of the adenoma may turn the nipple firm, nodular, or even deformed rather than erosive or fragile. And here you can see a microphotography from a patient that presented at the end of this talk. Look, here is the adenoma, here is the dermis, and here you can see the smooth muscle bundles, and between of them, this lesion, the Grant zone. So the lesion is far away from the surface, and its growth just pushes the tissue ahead, just evolving in an nodular, not erosive lesion. Like this is actually that patient. Another clinical caveat is that most cases are unilateral, but there have been reports of bilateral. And clinically, always remember, nipple adenoma may resemble a Paget's disease of the nipple. which is actually, regarding differential diagnosis, the most important pathology to think about. Nipple adenoma could be confused with Paget's due to its similarities as a sanguineous discharge, erosion, and pain. However, the peak incidence is later in life. Approximately half of the patients also present with the associated palpable mass. Now, there are, even before getting to Paget's, other differential diagnoses to consider, and the list is definitely not short. Again, the clinical presentation of Paget's disease and nipple adenoma may sometimes confuse us as clinicians, but for our colleagues experienced breast pathologists, as it could be sometimes very straightforward. Paget's disease is characterized by the presence of Paget cells. As we all know, you can see some of them here in the blue circles. In contrast, nipple adenoma, the growth pattern is completely different. You can see here this papillary-like pattern is way different than the other microphotography. And the myopithelium in the outer layer complete is also one of the key points of differentiation of the Paget's. The pathologist can see this aided by the immunohistochemical staining. As you can see here, and this is again another microphotography from that patient I'll present at the end. You can see the cells stained with P63, these little brown dots. The lack of myopithelial cells in the specimen are a positive staining for malignant cells markers, as we usually do. Let's say Ki67 HER2 hormone receptor ERPR can help distinguish nipple adenoma from malignant disease. Now, this could be definitely helpful for luminal lesions, but what about triple negative breast cancer? So even though we already said that there is no point on reporting histological growth patterns, it is still crucial for the pathologist to be familiar with these morphological growth features, as it remains very important to wait on this differential diagnosis. And last but not least, PIK3 and RAS mutations are frequently identified in nipple adenomas. There is even a series from Taiwan with over 50% of those cases with these mutations. I've said a couple of slides before that there is no clear data supporting malignant arise from nipple adenoma, but what we do really need to consider with the diagnosis of this is that the real independent risk factor for cancer in such a diagnosis is being associated with atypia. We know this for a long time now, and this is one of the reasons why the imaging findings is so important to rule out other entities in the breast. This is a paper by Wendy Berg from University of Pittsburgh, published a couple of years ago. After a 32-case review from their database in 2007-2021, they came up with a description of nipple adenomas on ultrasound, mammography, and MRI, being ultrasound the most helpful imaging method regarding nipple adenoma characteristics. In most cases, they found a slightly increased internal vascularity when using the Doppler, nor the mammography MRI demonstrated specific findings according to nipple adenoma diagnosis. Just on MRI, a hyperintense signal on pre-contrast, T1 and T2 weighted imaging, but again, not specific for nipple adenoma diagnosis. The complex surgical excision, since Dr. Hagen's paper is still the gold standard until today, remember, it's a benign lesion and simple excision is curative. Recurrence has been rarely reported after partial incision. It is important trying not to lose all nipple projections. Of course, it will also depend, as I stated before, on the clinical presentation and the compromise of the nipple, partially affected, total affected. Like this case where we needed to resect almost 100% of the nipple, and there is no projection remain compared to the contralateral nipple, as you can see there. And these are my last couple of slides. Look at this other case. We had a couple of months ago, a 34-year-old patient with a lump in her left nipple. There were no nipple discharge reported by the patient, no relevant familiar nor personal history. Physical examination showed a well-circumscribed nodule on her left nipple without any positive finding adjacent to the nipple alveolar complex. Here is a closer look to it. On mammography, look, there is only the enlargement of the left nipple, and there are some microcalcifications superior near the nipple, but not even suspicious. But look, on the ultrasound performed by our radiologist, Oscar Martinez, there is a slight abnormal increased flow, just like we saw on the paper previously mentioned. So this was the plan, using part of the healthy nipple to preserve the projection. This is the surgical specimen from our pathology department. Look how it grew towards the base of the nipple as it was deeper rather than the superficial. And of course, as I said before, it affected the clinical presentation. So what we did is a loose string suture at the base of the nipple once the adenoma was resected. And again, use the remain healthy nipple to cover the defect. Again, showing the microphotographies on your right, the florid papillary pattern. Here, the adenoma, the grand zone, the smooth muscle bundles, the healthy dermis, and how it pushes towards the surface. And here, the immunohistochemical staining with the P63 and the myepithelial layer complete. And this is the post-op. You can see the right nipple, the projection here on the right nipple, and then on her left nipple, how it is both pretty much preserved with an acceptable result. So I hope I'm on time, Yasan. These are the conclusions and to take home message. Nipple adenoma should be considered as one of the conditions in the differential diagnosis of patients with an erosive nodule of the nipple. Histological examination is essential to rule out breast malignancies such as ductal carcinoma, Paget's disease, and avoid unnecessary additional treatments. Simple excision is curative, recurrence is rare, and there is no solid data to suggest any link with invasive carcinoma. This is my team. This is my team in the clinic. These are my colleagues from the board of directors of the Venezuelan Society of Mastology. And with this picture of my beloved Caracas, well, I finished. I hope I was on time. I just stopped sharing, and I remain for comments or questions.
That's perfect, Victor. We'll take all the questions at the end when we finish all the talks. But it's a great presentation up to the point with a lovely conclusion slide telling you all the important bits. For people that are on the Spanish channel, I think Ricardo had an issue initially, but the Spanish channel is working all fine. So if you want to listen to the talks in Spanish, just choose the Spanish channel. And if you have any questions, because some people are raising their hands, Nazrina Chateau, I think it will be difficult to take the questions from raising hands. If you have any questions, please put them on the Q&A section. And the next speaker will be introduced by my co-chair, by Irini Pantiora. Irini.
Right, thank you, Yazan, and hello, everyone. Thank you for joining us. Our next speaker is Salim Tayeh. He's one of the breast surgeons on Homerton University Hospital in London. And his presentation is focused on breast infection and abscess management. The floor is yours, Salim.
Thank you very much. Can you see my presentation?
Looks fine.
Yes.
Yeah, okay, great. So thank you very much for the invitation. Good morning, good afternoon, good evening to everyone. I'm going to talk in the next 20 minutes. I'm going to talk about breast infection, concentrating on mammary fistulas and also touch on breast abscess and our experience with establishing a pathway for the management. Mammary fistula, fortunately, it is a rare disease. It's also known by other names like Zuska-Atkins, and I'll come to that in a minute when I explain in the next few slides. As I said, it's a rare condition, and therefore there wasn't much in the literature, definitely not a randomized controlled trials on the management. So I had to dig a bit deeper in history to get see the description, how was it first described. I came across this book by the famous French surgeon Velpu, who described the condition in his book in 1856, where he was describing the condition in lactational and non-lactational fistulas. And in this case, he was describing the fistula in Madame C, a 68-year-old lady who was diagnosed with a fistula, which he treated with compressive cloths. And also interestingly, I found what was hinted as a correlation between the mammary fistula and the abscess. And we know that abscess, an incision and drainage of abscess can cause fistula. And Thomas Nunn, in his book in 1853, advised against the early incision of the abscess to avoid the mammary fistula. And it was not until the 1951 when this landmark paper by Zuska and colleagues describing the condition and describing the pathogenesis and the treatment. And they advised for the excision of the terminal portion of the mammary duct to ensure the degrees of risk of recurrence. Interestingly, Zuzka's wife was diagnosed with bilateral breast fistula, and he got interested in the condition, and he then managed 4 further patients before the publication of his paper. And that's why this condition is all usually can be named by Zuzka's disease or Zuzka's-Atkins disease, because in 4 years later, in 1955, Atkins, a surgeon in Guy's Hospital in London, described the condition and the treatment in 28 cases where he opened the fistula and let it heal by secondary intention, and he had no recurrences in his series. Mammary fistula, what is it? It's a classical description. Fistula is a communication between 2 epithelial surfaces. In this case, one opening will be in the duct and the other will be in the skin, usually around the edge of the areola. Why does it develop? Incision and drainage of an abscess is a risk of developing a fistula. Also, spontaneous discharge of an inflammatory mass can lead to fistula, and rarely a biopsy of a mass can also lead to that. How does it happen? The pathogenesis, as described as, we know that the normal ducts are lined by cuboidal epithelium. In case of squamous metaplasia, a condition associated with the periductal mastitis, the cuboidal epithelium will be replaced by squamous epithelium, which secretes keratin, and that leads to keratin blocking the ducts. And then with the stasis and bacterial invasion, you'll develop microabscesses there, which will open and discharge, usually at the edge of the skin, because this is the least resistant area. Remember, there is a smooth muscle layer there, which is make it tough for the secretion to go through this way. So that's why they will choose the least resistant area. And once the block is released, then you've got your fistula. Smoking is a risk factor. We know that it is well-established risk factor for the developing of the periductal mastitis and abscess in 90% of, about 90% of cases. Congenital cleft lip is another risk factor for developing of this condition. Now, the management, there are no randomized controlled trials, but basically the treatment should concentrate on excising the fistula with the abnormal ducts and correction of the nipple. I looked at the literature and summarized the techniques described to treat the fistula into fistulotomy, probe the fistula, excise it, and then leave the wound open for secondary intention, or excise it and then primary closure, either with a circumareolar or radial incision, or a total duct excision, again using circumareolar or radial incision, and then some oncoplastic techniques are used. So I'm just going to show you some pictures from the series published. This is the Atkins series. He described the opening the fistula, leaving open by secondary intention, and he had no recurrences in 28 patients. And then the group from the same hospital, Guy's Hospital, in Headley's Atkins unit, described the same procedure in 59 patients, and they had 5 recurrences. Snyder described a radial incision where he excised the fistula and then part of the nipple and approximated the edges of the nipple to keep the nipple in shape. He described this in 18 cases and he had no recurrences. Lannon started with a circumareolar incision, excising the fistula, in 8 cases, but he had 5 recurrences. And then he moved to radial elliptical incision, and he had 2 recurrences after 26 cases. Dixon and colleagues advocate for the circumareolar incision. They've excised the fistula alone with antibiotics covering 15 patients, and they had no recurrence. And also combined the fistula excision with total duct excision in 28 patients, and they had no recurrences. I know that Mike Dixon is a big fan of a circumareolar incisions because he thinks that it improves the cosmetic outcome, which I agree with. And Lee and colleagues from my clinic also excised the fistula and also excised part of the nipple in 33 cases, and they had 3 recurrences. Jamal and Masad from Jordan described the total duct excision in 11 cases where he modified the technique by de-epithelizing the area above the incision there, and then attach the areolar nipple complex to this part. And he advised that this will create a new vascularized bed, reducing the chance of ischemia, and it also provides support for the position of the nipple. He had no recurrences in his 11 cases. Also, a group from Italy used oncoplastic technique here, some sort of round block where they excised the fistula and part of the nipple, and they described this in 27 cases with 1 recurrence. A group from China, Zhang and colleagues, used a dermoglandular flap for the treatment of 47 cases, and they had 2 recurrences. So as we can see, there are a few techniques described there, but unfortunately, there are no randomized controlled trials, but there is a meta-analysis by a group from China, Zhu and colleagues. So what they did, they grouped the interventions into 4 groups. Minimally invasive group, that's group 1, including incision and drainage, incision alone. And group 2 included the patients who underwent excision, minor excisions, which means excision of the fistula tract, by leaving the wound open or closing. So in minor excision, there were 4 subgroups: wound packing, primary closure with antibiotics or without antibiotics, and then minor excision with excision of part of the nipple. The third group was the group who had a major excision, either with circumareolar or radial incision, and the 4th group was the group with who had oncoplastic techniques. So this is a busy slide with all the studies included, but this is the important table. Here are the results. So they described or they calculated the treatment failure rate. We can see in the minimally invasive group, incision and drainage has a higher recurrence rate, but we know incision and drainage is not the treatment. And in fact, it can cause the fistula. So, so that's not treatment of choice. Coming to the minor excision, if you excise the fistula and leave the wound open, they have a good success rate. If you want to close the wound, make sure that you put them on antibiotics, because if you don't, then the failure rate is high. Moving to the major excision, it seems that the radial incision has a better success rate than the circumareolar incision. And the major plastic techniques had a good success rate. So that's the talk about the fistula, which is the rare disease. But I think I need to mention the next 5 minutes or so about the prevention. Prevention is better than cure. I'm trying to, in the next few slides, talk about the management of breast abscess, which is a common condition, but by properly managing the abscess, hopefully we'll avoid the development of fistula. Quickly go through the types of infection. The types of breast infection can be divided into 4 groups: lactational, non-lactational, skin-associated, and post-surgical. Lactational is common. Non-lactational can be divided into central, including periductal mastitis. and this is the concentrate of the talk, is mainly about the periductal mastitis that develops the fistula, and the peripheral infection, which is less common, but the etiology is less clear. It could be associated with diabetes, rheumatoid arthritis. Skin infection, like any other parts of the body, I'm going to skip that, and the post-surgical infection, I'm going to skip that to concentrate on the management of abscess. Management of abscess, basically the principles are to aspirate the pus and put the patients on antibiotics. Ideally, the patient should have ultrasound-guided aspiration because it is better than open incision of the abscess, and I'll explain why. There are national guidelines by the National Institute for Health and Care Excellence in the UK to advise on the management of breast infection and abscess. In the UK, most of, or all of the patients with breast infection and abscess will be initially treated by emergency physicians, emergency doctors, or general surgeons on call. So we thought by creating a pathway to guide our colleagues at the management, we should have a better outcome. I'm briefly going to describe the pathway. So the priority, of course, to make sure that the patients are assessed for sepsis. If they are septic, then they need to be treated accordingly with antibiotics and admission and etc. Then assess the suitability of ultrasound-guided aspiration. If the skin is necrotic, then they need to have incision and drainage. And in my experience, most of the patients will be suitable for ultrasound-guided aspiration. And we've provided the extension and who to contact to arrange for that. And once that's done, then the patient will be booked into the breast clinic for a follow-up. Summary of the management, that's based on the NICE guidelines, includes analgesia, antibiotics, aspiration of the pus. In lactational mastitis, first-line treatment is flucloxacillin and continue breastfeeding. Non-lactational first line is coamoxiclav and stop smoking if they are smokers. Did this pathway work? Yes, it did. We audited our results, looked at outcomes before the implementation and then after the implementation of the pathway. We looked at a few outcomes. After the introduction of the pathway, all patients had ultrasound scan done. The average time decreased, the average time waiting for ultrasound decreased. Almost all patients had antibiotics prescribed appropriately. For me, the most significant outcome was the decrease in the rate of surgery. Before the implementation of the pathway, nearly 40% of patients had incision and drainage, whilst after the pathway, that dropped to less than 10%. Reduction in surgery. Okay, well done, but so what? We are surgeons, yes, but I was told that a very good surgeon is a surgeon who knows when not to operate. So is aspiration better than incision and drainage? Yes, it is, but don't take my word for it. There's a recent meta-analysis done on the effectiveness of incision of needle aspiration compared to drainage. And that included 9 randomized controlled trials, including 703 patients. The outcomes. Cure rate was similar. So both procedures cured the condition. Recurrence rate, again, there is no difference, but healing time was better for the aspiration group. Incidence of breast fistula, and that's the monster that we want to avoid, was less with the aspiration group. Interruption of breastfeeding was less with the aspiration group. Satisfaction with the rate of the appearance was better with the aspiration group. So no difference in cure rate and recurrence rate, but the benefits of the aspiration is that better healing time, avoidance of fistula, and less interruption of breastfeeding and patient satisfaction. The last 2-3 slides I'm going to talk about. First, how are we doing? I don't think we're doing great. This is a recently published audit done to describe the current practice of mastitis and breast abscess in the UK and Ireland. The overall rate of incision drainage is 21. In my opinion, this is high. There's also a huge variation between centers, ranging from 0 to 100%. So some centers still treating all their abscesses by incision and drainage. And I think there's more work to be done. And the authors concluded that national best practice tool should be utilized. Now, I'll finish with a couple of slides in breast abscess. I would advise for the S rule for the management of breast abscess. Oh, it's nothing to do with my name, by the way, but I've just noticed that abscess has few S's in them, so the treatment should be there in S's. So I would suggest to symptoms relieve, stick a needle, sterilize bacteria, start antibiotics, suck the milk, and stop smoking. And if you don't like the S rule, then I would suggest that you treat abscess with abscess, antibiotics, breastfeeding, suck the milk, clean the area, educate and establish your own pathway using your own resources, stick a needle, and stop smoking. And that's my 18 minutes. And thank you very much for your listening. And I'll be looking forward to any of your questions.
Thank you very much, Salim. It was a great talk about a clinical challenge. I really liked the abscess acronym in the end. Very interesting. And now back to Yazan to introduce our next speaker.
Thank you, Irene, and thank you, Salim, for the lovely talk and sticking to time. Now it's Maggie Polichowski, and Maggie has been here before. She's one of the surgeons in Germany. She leads lots of the studies in Europe with the EU breast, and it's great to have Maggie with us again today. And she's going to talk about granulomatous mastitis. So Maggie, the next 15 minutes are all yours.
Thank you, Yazan. Dear colleagues, it's always a pleasure to be here, and thank you for having me. And particularly thank you for inviting me to talk about granulomatous mastitis and the opportunity of presenting an upcoming trial focusing on this rare disease guided by the EU Breast Study Group. So most of us have treated at least once someone with granulomatous mastitis, and most of us will still remember the patient because this is quite rare but might be very discomforting for the patient, with symptoms stretching up to months or even years and becoming a chronic disease. The prevalence is actually very, very low, 2 to 3 per 100,000 women in between 20 and 40. And there are very different hypotheses as to how granulomatous mastitis occur. Most of them assume that there is some abnormal immune process as a reaction, for example, to a trauma or maybe to an infection. And some authors have suggested that there might be a link with, for example, corynebacteria, but this has not been proven or established. The pathologist, who is actually the person who will confirm the diagnosis, sees granulomas, usually multiple granulomas in the tissue, and they are, in contrast to other forms of granulomas in the breast, usually located in the lobules. Sometimes there will be also an abscess present, but it is very important to know that the granuloma itself doesn't necessarily mean that our patient has idiopathic granulomatous mastitis, because this disease is actually a diagnosis of exclusion. And this is particularly important when you're dealing with a patient who might have one of these other diseases that you see here, and particularly in case of patients with tuberculosis or sarcoidosis, granulomas located at different parts of the body are not uncommon. So usually the pathologist who sees granulomas in the breast tissue following a core biopsy or a surgical excision will usually ask if there might be a suspicion of other diseases in the patient. And obviously, in countries where TBC is very common, this is a known phenomenon. For example, colleagues from Turkey have published extensively on this topic, and also about how to distinguish TBC granulomas from IgM, idiopathic granulopatous mastitis. IgM has first been described in the 70s, so it's actually not a very young disease, and it was described as a rare entity that might mimic a breast carcinoma. So usually the patient presents with a lump and also symptoms associated with an inflammation, pain, redness, swelling of the skin, and all these symptoms might mimic indeed a carcinoma, and particularly an inflammatory breast cancer. So it's very prudent to always keep in mind that one of our differential diagnoses will always be inflammatory breast cancer. So in the end, it's crucial to confirm the diagnosis by histopathology. What are the risk factors? Who is most likely to develop IgM? We do not know this because the level of evidence here is very, very low. We know that mostly women develop IgM, and women of childbearing age, somewhere between 20 and 40. Most patients reported in case series so far were 35. This was the median age in most publications. And the women usually had at least one child. The IgM developed mostly several months to years after end of breastfeeding. However, there are some cases in women who are very, very old, even as old as 80, and very few cases diagnosed in men or in women who are pregnant, which may be challenging for establishing a treatment strategy. Non-white ethnicity seems to be a risk factor in the studies that we have seen so far, and there have been multiple factors discussed as potential risk factors, like smoking or maybe autoimmunological disease in the past, and also hormonal contraception. But frankly, there is not enough data to talk about risk factors in an evidence-based manner. From what we know so far, there is no association between IgM and an increased risk of developing breast cancer in the future. But having said that, there have been some reports of patients having granulomatous mastitis and then being diagnosed with, for example, DCIS, ductal carcinoma in situ, following a surgical excision performed for granulomatous mastitis. But still, for our patients who have IgM and have healed well, there is, from the literature, no hint of having an increased risk of having breast cancer in the next years. When we perform imaging, usually the first form of imaging performed would be ultrasound, and then we see hypoechoic and usually very heterogeneous lesions, sometimes extended in one quadrant or in some patients even in the whole breasts. So we can see abscess formations, and some patients will also receive MRI. As we've heard before, our differential diagnosis is inflammatory carcinoma, and sometimes the patient who does not respond well to treatment will receive MRI because we're so concerned. And for the radiologist, it is quite challenging to exclude malignancy upon MRI if a patient has granulomatous mastitis, because he usually sees contrast enhancement. It might be mass-like or non-mass-like. There is usually some suspicious signal intensity. And there has been one very nice publication where colleagues from Turkey tried to distinguish between carcinoma, non-mass-like enhancement, and granulopatous mastitis enhancement in MRI, and it seems to be very challenging because most findings are actually overlapping. So let's talk about treatment, and here we do not have any evidence-based recommendations. We do not have guidelines on this topic because the disease is very rare. And as you can see, various different strategies have been employed so far. Most patients reported in the case series so far have received steroids at least once, sometimes local in form of an ointment. Some authors recommend injecting steroid into the lesion, and many recommend systemic steroids. And on the right side in the box, you see one of the possible regimens for steroids that is used at some sites here in Germany. So this is a prednisolone regimen starting at a quite high doses for 4 weeks and then tapering it over several weeks. So the total duration of therapy in case of IgM usually takes at least 2 to 3 months until you can wean the patient off steroids. In some case series, patients received full surgical excision, sometimes even a mastectomy in very persistent or recurrent cases. Usually this is not necessary, and there seemed to be in the literature a trend towards fine needle aspiration as well opposed to surgical evacuation. So this might be a good idea, but we do not have any trials on this so far, and of course no randomized trials. When it comes to other forms of systemic therapy, there have been different agents that have been recommended to patients, particularly immunosuppressive drugs like methotrexate, for example, but also some other drugs that we know from chemotherapy and also from treatment of autoimmunological diseases, bromocriptine, anti-lactation antigen, and most patients receive at least at first antibiotics. If you had patients treated for IgM, you probably know that usually if you perform a needle aspiration from the abscess formation, mostly they are sterile. Of course, we send it to the lab and ask for an antibiogram, but usually there are no bacteria in there. And if we perform repeated aspirations, repeated evacuations, they usually stay sterile for the whole time. There have been very rare studies on other forms of treatment like ozone therapy or microwave ablation, but this is something that has not been employed in many patients so far. One thing that you should definitely take with you is always confirm histologically the diagnosis, because the clinical presentation of the patient is very, very similar to the inflammatory breast cancer. So you always need histological confirmation before we start treatment, particularly because the agents we use, like steroids or immunosuppressants, might not be a good idea if we're dealing with a cancer patient. And here I brought you an example of a patient who presented with a large breast lump and also swelling and redness and typical symptoms of inflammation. And upon ultrasound, she had a hypoechoic lesion that has been aspirated. The lesion was sterile, and core biopsy confirmed the diagnosis of IgM. She has no suspicion of any other disease like TBC or sarcoidosis, and we started the course of steroid regimen. After 1 week, the lesion was smaller and her symptoms were better. She was also put on NSAID to reduce her symptoms. After 3 weeks, we saw quite a small lesion, and after 6 months, when she came for a follow-up visit, there was just a small residual lesion located in her lower outer quadrant. And there was still some redness and some skin swelling in this area, but the patient did not require any form of surgery. Sometimes, if you follow up patients for a long time, they might wish for a surgical excision of the residual lesion, particularly if they have some pain at this area. And this is also possible, but as I said before, there are no guidelines on this topic. The case series that have reported on a follow-up of their patients have shown that the patients have actually quite a high risk of having a recurrence of IgM, somewhere between 8 and 30%. So some patients we will be seeing again. And when I was preparing for this talk, I searched in PubMed, of course, for new evidence, and I was quite surprised that there seemed to be a certain interest in idiopathic granulomatous mastitis. But when you look closely, most papers that have been published 2021, and these were 66 publications. So the evidence is very, very limited. Then I dig deeper, and I saw that most publications come from Turkey. So many thanks to all Turkish researchers that have provided insight to this topic. There have been some publications from the USA, from China, and from other regions, but still it remains a very rare disease, and we urgently need more studies. And this is why it is my great pleasure to present shortly the GrammaRx study. It is a registry study designed by the EU Breast Study Group. Maybe you have heard of EU Breast. This is the study group that leads the XANA study, and in cooperation with the IBRANET from the UK, the MELODY study. This is how Yazan and I met. And the GrammaRx registry study will be led by my esteemed colleague from Düsseldorf, and Natalia Kavczyk, who is about to initiate this study in the next 2 months. So this study is a registry. It is observational, non-interventional. The target accrual is non-limited because obviously based on the rarity of disease, we want to start it as an open registry. And what I liked most, there will be a retrospective data collection. So all patients that had IgM between 2015 and the time point of activation of your study site can be included in an anonymized manner. They do not have to sign anything. There's no ICF for these patients. And then starting from the activation of your study site, you start recruiting for the prospective data collection. And here, obviously, the patients have to sign the informed consent form, and they will be followed up for until 5 years. And we want to gain more insight into this rare disease. We want to know how the symptoms are, how long the symptoms take until they resolve, what kind of treatment the patients receive. This is the part that I'm most interested in. Which factors contribute to a higher risk of receiving a surgery, for example, and how high the relapse rate is. So all the things that are actually very interesting to all of us, I'm sure of. All patients have to have histologically confirmed granulomatous mastitis. This is very important because we want to focus only on IgM. And we, of course, exclude patients having other forms of diseases that might lead to granulomas in the breast, particularly TBC, sarcoidosis, but there are no examinations that are mandatory according to the protocol. So if there is no clinical suspicion of these diseases, the patient can be enrolled in the registry. And this is the flow chart. And if you're interested, we're still looking for our international partners to conduct this study. You can look this up at eubreast.org. And this is my take-home message slide with all the important information. I must say I was a little bit disappointed how little we know about this study when we started talking about the registry. So I hope very much that this cross-border study will allow us to write real evidence-based guidelines in the future. Thank you very much.
Great talk, Maggie, and it's not easy to always to cover something as rare as granulomatous mastitis, and there's lots of questions in the Q&A section. You already can see 18 or 19 mainly about the IgM, and there's lots of on the chat function. So I think we'll have lots of discussion on the IgM. The next speaker will be introduced by my co-chair, by Irini. So Irini.
Right, I'm very happy to introduce Michael Bolland, an oncoplastic breast surgeon from St. Vincent's University Hospital in Dublin. He will be talking to us about desmoid tumors of the breast. You can go, Michael.
Thank you, Irini. Let me just share my screen. Okay. Good evening, everybody. My name is Michael Boland. I am a consultant oncoplastic breast surgeon working in St. Vincent's University Hospital in Dublin, and it is an honour to be asked to speak on iBreastBook, something I've kind of followed very closely over the last number of years. So I'm delighted to speak about this, and to Yazan and Irini for asking me. I think we have previously published on this, which is why I've been asked to talk about it. So I have no disclosures. So today I want to speak really just to define fibromatosis of the breast and speak a little bit about the current guidelines, which have changed quite significantly, specifically within Europe over the last decade, and then to talk about our own experience in Ireland of dealing with breast fibromatosis and a number of other studies which have detailed analysis of management, and to finish by concluding with kind of future strategies. What is this condition? Breast fibromatosis is a very rare entity and is a type of mesenchymal tumor or desmoid tumor involving connective tissue. Desmoid fibromatosis can be split into intra-abdominal fibromatosis, which is almost always associated with familial adenomatous polyposis syndrome, or extra-abdominal desmoid fibromatosis, which is where we come across it within the breast. It is exceedingly rare. Desmoid tumors are seen on average 3 to 4 times per million people per year, and less than 10% of these cases are seen within the breast. And so we see these very, very rarely, and certainly in terms of our own experience in Ireland, this was evidenced by the number of cases we had seen over a decade. The challenge with this entity is that it often mimics breast cancer, both clinically and radiologically. And so we rely very much on the expertise of our pathologists to guide us in terms of saying that this is not breast cancer, that this is fibromatosis of the breast. So what is it? Well, it is a monoclonal fibroblast proliferation that appears histologically as bland spindle cell spicules. It has low cellularity, it has a low mitotic rate, and it is actually benign. So it lacks metastatic potential, it lacks the potential to metastasize to other areas of the body, but it is locally aggressive. And so historically has been challenging to treat surgically and is associated with these stellar extensions that make margin management particularly challenging. The key to diagnosis within breast fibromatosis is immunohistochemistry. And as stated, the pathologist, it really is the key person within the MDT to guide us. When we look at this, these are two H&E stains for breast fibromatosis. We see the stain on the left, which shows these stellar extensions, and the stain on the right showing this very bland appearance with a low mitotic rate and almost acellular appearance to the slide that we see within this compared to, say, for example, a breast carcinoma. Macroscopically, this is a fibromatosis from an extra-abdominal wall tumor. And you can see here, I'm not sure if my cursor is working, but you can see here that the actual edges of this are very, very poorly defined. And this is what the pathologist will see when we send this from the breast, that it's very, very difficult to ascertain where this actually starts and where this stops. So how does this present clinically? Well, most commonly we see this in the clinic as a mass. It often occurs in patients both with a history of breast cancer and can also occur in patients who have a history of breast surgery. So if patients have had cosmetic breast surgery or have had obviously surgery for a malignancy in the past, that is something to consider. We see it most commonly obviously in females and in the 4th to 5th decade. And as stated, you should consider a history of breast cancer, previous surgery, and also a history of trauma, as evidenced by the paper by Newman et al. From Memorial published in 2008. The gold standard really in assessing for breast fibromatosis is cross-sectional imaging involving usually an MRI of the breast. A lot of these are incidentally picked up on CTs, but when we see these at the MDT, an MRI should almost certainly be performed. And what we see on an MRI, and I will go through a number of images later in the talk, is hypointensity to muscle on T1 weighted images and hyperintensity on T2 weighted images. And this area usually shows marked enhancement after gadolinium injection. Standard mammogram and ultrasounds are not particularly useful. Ultrasound often shows an oval-shaped abnormality, again, which I will show, but no obvious mass or necrosis that you may see within a breast carcinoma. This is one of the CTs. This is a coronal view of a CT from a paper from Lee et al., one of the earlier papers describing breast fibromatosis, and an obvious abnormality in the right breast. And you can see the propensity for this to extend, especially towards the chest wall, which makes surgical management particularly challenging. In terms of immunohistochemistry features, the positive stains we see are for vimentin, which is a filament within the mesenchymal tissue, as well as beta-catenin and smooth muscle actin. Negative stains are seen within things like prodesmin, cytokeratins, and S100. Breast fibromatosis or fibromatosis generally is sporadic in around 80 to 85% of cases and is usually seen with an abnormality in the CTNNB1 gene, which is the gene that is responsible for producing beta-catenin. And it's usually an abnormality within this gene that causes the proliferation of beta-catenin driven fibromatosis cells that causes this very, very dense proliferation of these cells within the breast or elsewhere. In familial cases, we see it in association with the APC gene, which is a tumor suppressor gene mutation, or what is known historically as Gardner syndrome. So I think what we will see in the next decade is an increase in the role of next generation sequencing for diagnosing this, and specifically for looking at abnormalities in the CTNNB1 gene mutation. This can actually be done on cord biopsy and is very, very sensitive in terms of confirming fibromatosis in other areas of the body. Unfortunately, it's not as sensitive within breast cases, but it is good at ruling out other spindle cell lesions. The other thing that you may see with next generation sequencing is looking at abnormalities within the WNT signal pathway, which is also responsible for beta-catenin production. And I think you will also see some activity within this in terms of using WNT inhibitors for treating fibromatosis of the breast. So in terms of how we manage this, I think there is an increasing value of these cases being discussed at length at the MDT, and having a dedicated both breast pathologist and I think in time sarcoma pathologist who has experience in looking at these abnormalities under the microscope. Historically, these cases were managed with surgery, but in the last decade, as I stated, there has been an increased focus on the use of active surveillance. So all patients require discussion at the MDT and value the input of your pathologist, and certainly they will provide very, very good information, or should provide very good information as to whether or not this is fibromatosis based on the immunohistochemistry. As stated, the historical standard of care was surgical intervention or surgical excision, and this does remain an option. But because of the locally aggressive nature of breast fibromatosis, we found that patients who are having surgery for this often required mastectomies, and in some other cases, radical mastectomies with often debilitating and very poor cosmetic results. And it was not clear whether or not margins actually affected the longer term outcomes or recurrence rates for breast fibromatosis. Certainly in recent years, there has been a meta-analysis published in the BJS by the group Janssen et al., which demonstrated that clear margins did affect the risk of recurrence. And what we can see here is the forest plot that demonstrates an increased risk ratio for positive margins for the development of recurrence of disease. However, the evidence on this is mixed. A paper published in JCO by a group from Bordeaux, Salas et al. Back in 2011, and probably the largest breast fibromatosis paper by Roussan et al. And the Bonvalot et al. Group, which basically has demonstrated that the rate of margin positivity does not improve outcomes. So in the Salas paper, which looked at fibromatosis, extra-abdominal fibromatosis throughout the body, they've over 400 patients. And really, they found no difference in 5-year progression-free survival between those who had an OR0 resection and an OR1 resection. The Roussan paper, published in the European Journal of Surgical Oncology in 2015, looked specifically at breast fibromatosis and had 20 patients, 9 of whom had clear margins and 9 of whom did not. And again, no difference in recurrence at a median follow-up time, with 8 patients developing a recurrence between the two groups. So the question then arises, is surgery really necessary for this? And, are clear margins necessary? And would our historical friend, Mr. Halstead, be turning in his grave at the thought of not operating on breast fibromatosis? Well, in the last 10 years, we have seen a significant shift in terms of patients being placed under surveillance with breast fibromatosis. So again, the Roussan group looked at 11 patients treated with AS or active surveillance and found that 88% had a median follow-up of over 40 months and developed stability or regression without any treatment at all. And this really impresses on surgeons the benefit of avoiding mutilating surgery in patients who require extensive resections, and many who, as stated, will stabilize. Following this, the systematic review meta-analysis published by Tim Bergen et al. In the European Journal of Cancer, involving 25 articles, again demonstrates a stability or regression rate of close to 80% at median follow-up time. And as a result of this, both the Desmoid Tumor Working Group based in France and the European Society of Medical Oncology now advocate active surveillance for breast fibromatosis, which is a significant shift from the historical option of operating on all of these. But who should we operate on? Well, the switch to active treatment or surgery usually occurs in around 30% of cases, and the most likely patients who will require this are those with a younger age, those with painful tumours, and most specifically those with larger tumours that are particularly aggressive and without surgical intervention are likely to cause very significant problems. Other points to note is that grossly positive margins, or OR2, where there is clearly tumour left behind, is certainly to be avoided if you are operating. But OR1 margins are acceptable if they are going to be associated with a high morbidity if you're trying to achieve an OR0 margin. We do advocate that patients avoid pregnancy within 1 year of surgery, as this tends for some reason to accelerate the rate of growth of breast fibromatosis. What other treatments can we give? And I think the importance of some other randomized trials we've seen in the last number of years have looked at systemic therapies that can be used for breast fibromatosis. So specifically the DESMAPAZ study, which was published in Lancet Oncology by Tuamond et al. A number of years ago, looked at the use of pazopanib, which is a tyrosine kinase inhibitor, as well as the New England Journal of Medicine paper looking at the use of sorafenib. And these showed an objective response rates close to somewhere between 25 and 40%, which are very, very reassuring in terms of patients with breast fibromatosis, and demonstrate again the ability to stabilize patients and in some patients cause significant regression of disease. The other drug that has been looked at, which is a gamma secretase inhibitor, nirogacestat, was looked at by Kumar et al. In a phase 2 study published in JCO, and again showed an objective response rate of around 30%. Other medications that have had some evidence in favor of them include hormonal therapy, including tamoxifen, more aggressive cytotoxic or standard chemotherapy agents. And as stated before, there is some current investigation in terms of WNT inhibitors, as it is involved in the pathway with beta-catenin. So in terms of guidelines for active surveillance, we would recommend that if you are placing a patient on this pathway, that they would have an MRI at diagnosis, that they would have an MRI at 6-month intervals for 3 years, as well as clinical review, and an annual MRI thereafter. So I want to talk a little bit about the management of breast fibromatosis in Ireland and the study that we had published. I've included a picture of Dublin and a picture of St. Vincent's Hospital down the lower right where I work, and St. James's Hospital, where the other centre that we included. And all three of these pictures have Dublin looking very blue-skied, which it is categorically not. So I think it just tries to give a better picture to the listeners today. So we published this paper a number of years ago, and this is a paper that I wrote in conjunction with Professor Elizabeth Connolly, Professor of Breast Surgery in James's Hospital, and with my previous mentor, the late, great Enda McDermott. And this was a paper between 2 institutions in Ireland, which looked at fibromatosis of the breast over 10 years. So we had 16 patients, all of whom were female, and a median age of diagnosis of 42, and 11 of 16 of these had presented with a lump. 1 patient had a history of breast cancer, 1 patient had a family history of breast cancer, and 1 patient had a known APC gene mutation. Mammography was performed in 14 out of 16 patients, and abnormalities seen in 11. And the most common abnormality we saw was a distortion. I think what you can see in this mammogram, which is one of the patients from our study, was this very kind of significant distortion in the central and lateral breast on this CC view, but no obvious mass that we saw really in any of these mammograms. Ultrasonography performed in 15 out of 16, and again, a textural change. And looking at this ultrasound, we can see this kind of very distinct abnormality with, again, these obvious kind of extensions from the abnormality, which was very pathognomonic for something like fibromatosis. Finally, MRIs were performed in 8 of 16, and the MRIs were particularly useful with obvious masses. And you can see in this MRI the mass, and I think this MRI was very useful to demonstrate the involvement of the pectoralis muscle within this patient, and that is something we see commonly in fibromatosis of the breast. In terms of the immunohistochemistry, we saw beta-catenin positivity in up to 70% of patients, actin positivity in nearly 50%, but a low level of S100 and desmin positivity, and a low level of CD34 positivity. 13 patients underwent surgery, 10 of which had a wide local excision and 3 of which had essentially a diagnostic excision, because in the earlier part of this study, the diagnosis of fibromatosis was still very challenging. And 3 patients in the latter part of the study were placed under active surveillance. Of those that had positive margins, of those that were operated on, 8 had positive margins and 6 underwent re-excision. And of those who underwent re-excision, there was absolutely no effect in terms of the numbers that developed recurrences. We saw 3 recurrences within the 13 that had had surgery, all within 2 years, and all of which, because of the changing paradigm in terms of how we manage this, were then treated without surgery and placed on active surveillance. So in terms of the 3 recurrences and the 3 patients who had initially been placed on active surveillance, all stabilized and none of whom required surgical intervention within a median follow-up after the 10 years of roughly around 5 years. So we saw a significant change in approach over the decade. Margins have become certainly less important, and recurrences within this, certainly in our study, were common. 2 other very quick studies to mention. I think the seminal paper published from Memorial on fibromatosis of the breast came in 2008. This is a larger series, 32 patients, all of whom had surgical intervention because of when they had their diagnosis, but a significant recurrence rate. And they found that recurrences were more common in patients at a lower age, as I alluded to earlier, those with positive margins and those with larger tumors. 25% of those who had fibromatosis had a history of breast cancer, and as stated before, 44% of these patients had had some previous breast surgery. And recurrences, when they occurred, tend to occur early, similar to our experience in Dublin. The second paper, and probably the largest paper from the Bonvalot group, and this was a paper by Ludwig Duhaze-Cassin, published in Breast Cancer Research and Treatment in 2019 from the French group, really looked at this is the largest series we have, which is 63 patients. And of these, 46 patients underwent surgery and 17 were placed on active surveillance. And of those 17, 15 have not required surgery in the follow-up time, again, of over 40 months, with 2 proceeding to require a wide local excision. In terms of those who did require surgery, there was a 5 positive margin rate. 5 had what they described as radical resections with very, very poor cosmetic outcomes. And 4 patients, which is a low rate compared to other series, developed a recurrence. So to conclude, I think it is critical that you put these patients through the MDT, that you have a dedicated breast pathologist and possibly a sarcoma pathologist to review the slides if possible. The current guidance would state that these patients require active surveillance with clear guidance on the mode of surveillance that is required and clear guidance on those that may require surgery, depending on the factors that develop. Those factors include patients that are younger, have larger tumors, and have particularly aggressive tumors. But it is increasingly important to explore the role of non-surgical options, including tyrosine kinase inhibitors, specifically such as sorafenib, in terms of managing this. Thank you.
Thank you very much, Michael. It was a great talk, very nice overview of a rare but rather challenging diagnosis. Going back to Yazan, so we can start with the questions and discussion.
So let's open the videos for all the panelists and speakers. We still have Salim, we have Naeem also online, and Victor, do you want to open your
I'm not able to open my camera.
Oh,
Thank you.
it's fine. Okay.
You stopped my camera, Yazan.
You can start it again.
I've tried.
It said it's unable.
Oh, is it? More.
But I can hear you just fine.
I think you have stopped it, yeah.
Yes, you have.
I've sent you an ask to start videos. Has that worked at all?
There it is.
Yes, yeah. Now we can see you.
Perfect, and I can see you. And
Right.
that's
Okay.
perfect. Yeah. Now we have the full cohort. So thanks for the 4 speakers. Thanks for Maggie, for Michael, Victor, and for Salim. Now with the panelists, we have Irini, the co-chair with me, and we have one of the usual serial offenders and the usual suspects, Ash. It's great to see Ash online today. And we have also Prof. Naeem Kadoglu, who's one of the surgeons also in London. And Naeem sent me an email, Maggie, because they've written a book on idiopathic granulomatous mastitis. So that might be very interesting and might be something to look for.
Yeah.
Because there'll be potential for collaboration in the future.
Yes. Thanks. Yes. Yeah.
So shall we start with the first talk? So the first talk was the nipple adenomas. And for me, location is very important for the nipple adenomas. The base is very important because excising it is not always as straightforward as it can be. And always, as you've shown in your lovely video, Victor, sometimes going into the breast tissue, if you don't do a full excision, recurrence is an issue. But do we need to operate on all nipple adenomas? Any comments on that? Because there's lots of questions. Do we really need to operate on all those adenomas?
I think we do. I think we do because again, it will keep growing, And sometimes, as I said in one of the slides, it could behave in an infiltrative manner. So again, if we're looking forward not to lose all the nipple, for instance, we should excise. The other thing is that if we perform a pre-op biopsy, let's say a punch, I don't know about the rest of the panel, but it's not going to be few times that the pathologist will require the excision of the complete lesion in order to see the adjacent tissue and if there's definitive an infiltrative component there. So again, I think for the moment, we still need to operate them.
But I think we all do the biopsies mainly to confirm diagnosis because you don't want to be missing a paget or missing something else. And then
That's right.
So it's I don't think that anybody here, will you operate without, will anybody here operate without doing a punch if you see a nipple adenoma?
No.
No, recent experience. I had a patient a few months ago where she was suffering for about a few years before we decided to excise the nipple. So I think I agree with Victor. I think the way straightforward is to excise the nipple. Yes, but I wouldn't do it without a biopsy beforehand.
I've seen one recent lady, her nipple adenoma is 5 centimeters at least, taking the whole base of the areola now. And if you want to excise it, you want to remove the whole nipple areola complex because you cannot excise it if you look at her. And she doesn't want anything done. And it has been growing slowly for years and years. She doesn't want anything done. Any comments from any panelists?
Yes, yeah. May I tell something, Yazan? So I think we have no just right to operate any adenoma without any core biopsy. That's my, view. And that's, basically the practice here in UK. And just, I would like to tell you about my recent practice. About a few months ago, I have seen one young lady breastfeeding in her late 50s. I think she was 52, 53, and she was breastfeeding, presented with a nipple adenoma type picture. And I was very keen to operate on her, so it just was very difficult, to do. I just suggested biopsy. She declined biopsy, and she came on the day of surgery. I said, no, I'm not happy to do it. And I did the biopsy in theater because she declined. She wanted to be done under general anesthetic, and it showed basically reaction. It was, inflammatory reaction. And after the core biopsy, I took at least through the nipple core biopsy 4, 5, and about a month later, it disappeared. I was nearly to take it, was looking real adenoma, and she insisted on basically to remove that area. There is no evidence, to do any, basically no indication for surgery without biopsy. I wouldn't proceed without. I think this is, it might cause a lot of medical legal problems, if you do without any core biopsy, if you operate any nipple adenoma.
So we agree we'll need to biopsy all the lesions before we take them out.
So that's, it has to be a rule.
But the other thing is that, let's say we excise the nipple adenoma and you have clear margins on it. Do we need to follow them up or not? Any comments on that? Victor, anything was there in the literature about follow-up? We don't tend to. If there's no completely excised, we just tell them if there is any problem, you come back.
Actually not. And the recurrence numbers are very low. The thing is that we need to have a very good imaging pre-op scenario as the differentiation with the Paget's disease, as I said it before. And I think that's much it. I don't know about the rest of the panel. If they, in their institution, they have a working follow-up with these patients.
And any comments about that? Ash, any comments about nipple adenomas? Anything from your side?
So I think probably we are over-treating those patients. So we need, I think, more evidence, more international collaboration, more evidence, really we don't know how to approach those patients. And there are different approaches from different parts of the world. So I think still we are very aggressive to treat nipple adenomas. That's my personal view. We need to be really very cautious about it.
Ash, any comments on that?
I think I agree. Unless the patient is symptomatic, I wouldn't treat an adenoma and definitely won't follow her up.
So let's move from adenomas to the infections and fistula. So I think the key message from the talk, Salim, is that most abscesses you can treat with aspiration and antibiotics. Many people are still taking patients to theater, making big holes in breasts, and that's how you end up mainly with fistulas. There's loads of questions on the Q&A section. What's the duration of antibiotic? When do you stop the when do you stop the antibiotic and aspiration and go for surgery and things like that? Common sense is common. So if the patient is septic, not well, need to go to theater, you take them to theater. If the patient is not responding with the repeated aspirations, then that's when you start thinking about taking them to theater. But the majority will not heal in a week or two. Some people need to take 2, 3, 4 weeks, and they need to come frequently to clinic, have ultrasound scan guided aspirations, and take the antibiotics, and they're responding. Any comments from anybody about that?
Absolutely. I want to stress the E letter on the abscess, the educate. It is crucial to reassure the patients and educate them to, well, they're breastfeeding, they're frustrated, they've got this abscess. They need to be reassured that it is likely that they will require that more than one session, and they just need to be patient. It's much better than taking them to theater and incise the abscess. So educate the patient is a very crucial. In terms of the indications for surgery, if the skin is necrotic, that fine, I agree, that's an indication. But and again, failure several attempts of aspiration may be another indication. But in my experience, most of the patients will be suitable for ultrasound guided aspiration.
Or sometimes just clinical aspiration. You don't always need the scan guidance, in all honesty. Maggie, you have your hand up?
Yeah, we have a very similar problem in Germany, so that too many patients receive surgical drainage and not an aspiration. And I was wondering, is there an incentive in the health system in the UK so that it's easier or better for the department to perform surgery than to aspirate? Because this is clearly the case in Germany based on our reimbursement system.
Yeah, sometimes the money comes into the equation, unfortunately. I have Naeem and I have Michael's hands up. Do you have comments from Naeem first?
Yeah, so I think just, I would like to address basically the UK experience. There was a very good paper of Prof. Dixon about breast abscess, this has been published quite a long time ago. And we have published also about breast abscess in the European Journal of, breast. And what I see is, I feel guilty basically letting, non-breast surgeons to drain breast abscesses. We see really very big incision. There is no really indication for any drainage unless if there is an obvious skin necrosis or very thin skin. And nearly I think probably my personal observation is not more than 5 or 6% of patients might need drainage. 96% can be basically treated, conservatively with, proper aspiration. And this aspiration has to be done by radiologists with dedicated breast radiology. This is also a second important thing. I think we need to be in all countries, as breast surgeons, we need to take over the drainage of these breast abscesses. And because, we will end up with a very small incision at the end, it makes huge difference. And that's, something that, I don't know in how many countries, our breast consultant colleagues are being on call, are going for drainage of abscesses. So that's something that we might consider for breast abscess.
As you say, Naeem, in many parts of the world, the classical teaching is incision drainage. Even when you look at the papers that Salim shared, in the UK, it's still about 20% are ending up in theater, 21%, which is a very high percentage. And that's a national audit. But from personal experiences and from experiences like in Salim's their own paper is less than 5%, but less than 10%. And I know in many places that they have dedicated radiology. So, for example, I spent a year in Guy's. I don't remember draining any abscesses in Guy's. Everything was done under ultrasound scan guidance. Nothing ended up in theater. Am I correct in saying that, Ash? It's very rare for people to end up in theater with breast infections.
So over the last 20 years, we haven't drained one with incisional drainage. And where you talk about skin necrosis, if the skin necrosis is small, I wouldn't incise it. I'd wait for the skin to necrose and for the abscess to auto-discharge.
Yes.
There's no point of giving the patient an anesthetic, taking out the theater and excising skin. So skin necrosis, I don't think is an indication for surgical intervention.
And Michael, you have a comment?
Yeah, it's just to echo, I think, what Naeem has said. Certainly, I was involved with the MAMA paper that Daniel F. has kind of overseen from Imperial. And like the overwhelming finding from that is the patients who end up having an incision and drainage are those who are admitted after hours, those who are admitted over weekends, and those who come under the care of general surgeons. And that's not a criticism of general surgeons, but I think, as Salim referred to in his talk, like the introducing a pathway within your institution whereby the ED team knows that there is a very specific pathway for these patients to require ultrasound guided drainage is absolutely key, because if the general surgeons and the ED guys know that, then even if it's a patient who is admitted over the weekend and there isn't a breast surgeon or radiologist around, those patients almost always can be put on IV antibiotics, even if they're required to stay in if they're unwell, and then have an ultrasound guided drainage on Monday. And we can really drive that 20% figure down to the kind of 2 or 3% figure that where it should be at. So I think if you're in an institution where you're involved in a breast service, actually delivering that and getting a pathway to avoid patients requiring an IND in theatre is critical.
Before going from abscesses to fistulas, I think Salim has his hand up, and then Irini. So Salim first.
Yeah, I mean, in terms of there is an issue with the patients presenting in the weekend. And I always advise my colleagues and junior colleagues, you don't need an ultrasound, really. You can just stick a needle, how much pus you can aspirate, they'll give them some relief, and then they can come back on Monday. So you don't always need an ultrasound-guided aspiration. You can just do it with a needle.
And Naeem, is your hand a legacy hand or is it a new hand?
Yeah, so okay. So I would like to tell something. Yes, so when we are encouraging all our patients to breastfeed, okay, so we know that it helps also for the treatment. My main question to Salim will be, what's his suggestion about MRSA positive patients? So we have just rarely, with this kind of patients with MRSA positivity. Still, do we need to suggest them to breastfeed or not? What's his suggestion? So he has a lot of work done about breast abscess, and just if he can highlight his views about it, please.
I don't have a specific view. I usually follow the local protocols by the microbiologist.
Yeah, so I think we need to be very cautious about it. I know we don't have, again, very clear indication, but I am really very cautious about it. With recurrent abscesses, all the time we need to check also about the possibility of, MRSA positivity. And that's, strong suggestion of all my colleagues, who are listening to us.
Was your question about breastfeeding, whether there be a
breastfeeding MRSA positive patient? What's your...
I don't know the answer.
Any other comment from other, panelists?
Any comments, Ash, Maggie? I don't think there's any contraindication, but Ash, any thoughts?
So if you look at the CDC website, it says that you can breastfeed with MRSA positive infections.
I don't think there's any contraindication. It's MRSA can live in throat and nose, and it can live anywhere. So, but always involve your microbiology and infection control department to see how you can clear that. Irini, any comments?
And I just wanted to comment on the previous discussion about the pathways and what we do with the patients that come during the weekend when there's no availability of breast surgeon. I just wanted to say a bit about how we do in our unit. We do have some institutional documents for guidance for the on-call surgeons. So it's usually pretty straightforward, and they just follow a pre-designed pathway for all these patients. So we've kind of we're okay with this issue. We don't really have huge problems, and they just refer the patient to us for follow-up if needed.
And it's very easy for people just to copy a protocol from somewhere that works and just use it in your emergency department. If it works elsewhere, it should work also in your emergency department to decrease those incisions and drainages, because that's when you end up having fistulas. We rarely see them. We see them mainly in smokers with periductal mastitis, but like Salim showed, there sometimes can be tricky to treat. You have from the simple operation to the more complex procedure. But a couple of key things: if people are still smoking, they will have the recurrence. I don't know, will you operate on smokers if you have somebody with a smoker with a fistula? Will anybody operate on smokers? The recurrence rate is nearly 100%. So they need to stop the smoking first.
Yes.
And if they stop smoking, still the recurrence rate is quite high. And you've shown beautifully from simple procedure like incision drainage to a more complex fistulotomy and fistulectomy to a more complex oncoplastic type of procedures. Recurrence rate is not that much different as long as the fistula is out. Not with a simple operation, but as long as the fistula is out. Am I correct in saying that, Salim? Or
Yes, that's right. That's right. Yeah, there's not a huge difference in the success rate, but I wouldn't go that extreme and do the oncoplastic techniques unless it is a wide area complex fistula. Otherwise, excision and primary closure, my experience, will do.
Exactly. So the ones that you showed, they have de-externalized quite a bit to mobilize the nipple and do that. I wouldn't venture into doing those things. This nipple is already under had lots of problems, and you can cause more and more problems with that. So I think just a perioral incision, excising the fistula. Some people lay it open, some people will close it and cover with antibiotics. The main, you said it when you did you showed how it works. The change of the lining from cuboid to squamous, that's the issue. The squamous will never close. You need to get rid of that. And if you don't change the lining, then it will not heal.
I'll be interested to know Ash's experience, because I presented one of your papers. I think you're an advocate for openly the fistula and leave it open by secondary intention, and that was Atkins' procedure. And you've published the series. And is this what you still practice, or do you close it?
So this was the days of my mentor, Professor Fentiman. So like you said, that was what they used to do till our generation came, and we now primarily close everything under antibiotics. But I was also going to ask you, do any of you take out the ducts, do a total duct excision in a postmenopausal woman with a fistula?
The recurrence rate is lower, but you have to consider whether they're planning to breastfeed or not. If they're not planning, then yeah, I would do a total duct excision.
And that's what I learned. I think also, guys, when I was with you, Ash, it's just you open the fistula, clean everything, and if you can do a total duct excision, that will decrease the local recurrence rate. Sometimes I put negative pressure dressing. That also sometimes make a big difference on their healing, but the recurrence rate is still not low. Last point about the fistulas before we move to the granulomatous mastitis. Naeem, you have your hand up?
Yeah, so I would like to ask something to panelists, also to my colleagues, just all other colleagues, who are listening to us, the main question, with breast abscess patients is, how long, after stopping, the smoking, all the problem can be sorted out. I think my just answer all the time is there is no real answer about it. Even after stopping, the smoking, still the damage to duct epithelium is continuing, for long term. And we don't have any data really, just, to say the truth to our patients. I know still the risk is higher, but of course less than, definitely than the smoking period. Any suggestion about, do you have any, just any evidence, to any time, just about, how long does it take, the risk is becoming minimal, the recurrent of abscess? Do you have any?
I think the risk will still be significantly high. It will not be minimal.
High, of course, but any time.
Yeah, we usually quote them. I usually say that if you still smoke, it's 100% recurrence rate. Might happen soon, might happen later. if you stop smoking, is much less than that. Was there any numbers in the literature that you looked at, Salim?
I'm not aware of any published data on this specific topic. No, not that I'm aware of.
Okay.
I couldn't see any just suggestion about it.
It's very difficult to put a timeline on that, I think. Maggie, very interesting talk. Loads of questions online about idiopathic granulomatous mastitis. I think you'll see that much more in the Middle East. In all honesty, that's Naeem has written a book. You've seen lots of literature is already from Turkey. I know I've seen some talks also from Egypt with loads of cases. We've seen Sadaf from Iran has just mentioned on the chat that they have 300 cases that they published from Iran. Also, you'll see that lots of in that part of the Middle East. While here, for example, in the UK, I've seen nothing until COVID hit. And then after COVID, I've seen 2 or 3 patients in a row, and then that stopped again, about a year after COVID started. So it's always very interesting. I think Irini have a couple of questions for you, and she has her hand up already. Irini, you want to say something?
Yes, well, I do have a question for Maggie. We recently had a patient with granulomatous mastitis, a young lady, very hard case, very challenging, open wounds in her breast, 3 or 4 spread around the whole breast. And we excluded everything else, took biopsies, excluded tuberculosis and vasculitis and everything. So we started her on cortisone, but we also used negative pressure systems. Have you tried those? I mean, it really helped in our case.
We have been using those in plastic reconstructive surgery, but not for IgM cases. But yes, I've heard that there have been reports of using these. Actually, when you look into the literature, there are so many different strategies that have been used, like ozone therapy or treatment with local collagen. So there have been no trials on this, but based on the data from the reconstructive setting, well, if nothing else helps, I would give it a go. How long have you employed negative pressure therapy?
She had it for 3 weeks. And after that, we noticed a huge difference. And then we just continued with the cortisone until we weaned her off. But yeah, I think she had a wound that was 5-6 centimeters and it just disappeared.
Yeah, my personal view, Irini, is just even if you will wait, just it will heal spontaneously. So just, I'm not sure really about the real indication of the vac dressing in these cases. But what I would like to tell is just, most of the time, even if you will wait, this case will heal spontaneously. That's what I would like to address, just IgM is not surgical disease. Definitely, there is no any place for surgery. And as Yazan told initially, the beginning of just the presentation. So recently we published the first IgM book, with my colleague Professor Hande Göksel from Turkey. Okay, Hande has done a lot of publication about it, and because of my personal interest also, I have been involved in, and we end up, writing the first IgM book published by Springer recently. I'm sure it will help our colleagues and just a lot. And now just recently, I have been invited for consensus meeting to Turkey at the end of October about IgM, because I feel really guilty to talk about IgM, because as Yazan mentioned, our basically experience is very limited here in UK, but a lot of cases in Turkey, and just you will see most of the publications are from Turkey, from Iran, and just we have been just in that consensus meeting about 30-45 breast surgeons, and we are in the process of just basically writing new guidelines, new classification, and hopefully evidence-based, just treatment options of IgM. My personal observation is, we need to establish basically in each hospital IGM group. And just we need basically multidisciplinary team group of breast surgeons, then just ID team, dermatology, and rheumatologist. This is the essential. We need to know from the initial point, we need to follow up those patients properly. This is the only way to treat, the IgM patient. It's very difficult, very complicated. It is a really very mysterious disease, and it might mimic cancer. My strong suggestion to our audience, we have colleagues from different parts of the world. Of course, the conditions are different in different parts of the world. Never, trust your surgical experience and to directly, just basically operate those patients. We have cases, I just heard about cases operated as a cancer, and at the end, the histology came back showing, just IgM. So that's why we never operate in this country.
But that's the key thing from Naim. The main idea from this today is that the two cases I've seen looked like cancer. They were biopsied so many times, 5-6 centimeters, got even bigger and worse, but we sat tight on them. It's a medical management for those. They need the treatments, and that's the key thing. Don't start chopping those areas out. You'll see lots in the Middle East. I don't know, Victor, do you see IgM in South America quite a bit or not? Is it something that is often seen?
Actually, it's not that often. Last year, I think we had maybe one for sure, two maybe. But before that, the last IgM we had was about 5 years ago, 6 years ago, something like that. It's not that common.
And the key thing is consensus would be great to have a consensus, but we need more data, and that's what also Maggie is doing. And when we get more data, and I think the target audience should not be mainly in Europe. You will not get lots of patients from Europe. You might get some from the eastern part of Europe, eastern part of Mediterranean, also in the subcontinent, in the Middle East. And when you get data, then you don't only give consensus, you can have more data to give better guidelines. So data is very important part of the equation that is missing. And because we're basing things mainly on case reports and case series. Ash, you had your hand up?
So I think Maggie, you go first and then I'll go after you.
Thanks a lot. I was overwhelmed by the number of questions that popped up in the chat, so I have tried to answer most of them. It was a very important comment by Naim, and I believe as well that there is a high probability of spontaneous healing of IgM, and I have seen cases where I remember one patient 15 years ago, it was a very severe case of IgM, and we have tried everything, immunosuppressants and steroids. And there was even some talk about a mastectomy because the patient was so, disappointed that it doesn't go away. And then at some point, she just disappeared. She opted for very unconventional therapy outside of evidence-based medicine. It was some form of collagen gel that she received for a longer time. And then when I have seen her again 6 months later, the breast looked wonderful. It looked normal. There was no sign of IgM. So maybe it just healed spontaneously. Maybe it was this mysterious collagen gel that she received. No idea. But there is a potential of self-healing here. Thank you for this comment.
Many self-limiting, isn't it? Ash, you say?
It is, because I don't think the gel had anything to do with it. It would have healed regardless of the gel. But the question about when you do a study across different countries and different practices, the problem is going to be harmonizing what kind of tests have been done, whether they tested for Corynebacterium, all that kind of. So because it's data is rubbish and rubbish up. So you have to make sure, especially when you're trying to get something like a consensus, which Professor Naim is trying to do, is you have to standardize what tests are done, whether there's a trial of antibiotics given, what treatment is given, and then look at the outcomes. Because otherwise, everyone does a little bit here and there, and then you have this whole heterogeneous data, which doesn't make sense.
And maybe the consensus, maybe just to look at what data should be collected. One last little quick comment, Naim, before we go to the fibromatosis, because we have only 10-15 minutes left.
Yeah. So
Don't
what
say
I
something.
would like to tell, so just, yeah, and we need really consensus meeting about it, just we will map the treatment options properly, evidence-based treatment options after this Turkish consensus meeting results. So we will publish it. And I'm aiming to write, just to our Association of Breast Surgeon President and to have national audit here in UK to collect all total number of your IgM cases. And and we might be center. There's a Norfolk Park, the London Norfolk University Hospital. As an IgM center, I think we have all the right because already the St. Mark is for the basically inflammatory bowel disease center. So it will be it's a very interesting topic. Basically, it requires a lot of research activities. And we might, specifically, there was very interesting, basically just learning for me in this Turkish consensus meeting. One of the Turkish colleagues, mentioned about leech treatment in just, with a no recurrence in, if I remember well, in 3 years' time. That's quite interesting topic, really, we need to have a proper MDT team to decide about the treatment of all those cases.
It's time is a great healer, and many of the times that's what you need for those patients. And the lovely comment from Karen Barbosa, that time heals the breast surgeon and the patient. So it just needs some, because also sometimes the surgeons are a bit impatient and they rush into doing things that are not always needed to be done. Now it's time for Michael. And it's a lovely talk, something that we rarely see. It's good we have one on the MDT next week. So it's very well timed talk. So if we have done the excision, when you talk about margins, what's a negative margin for those? Is it just?
Yeah, like this is something that was quite difficult to standardize, which probably why I didn't include it in the talk, is that there doesn't appear to be a definition of margins similar to the way we would define margins with regard to invasive or pre-invasive disease. I think a lot of the papers use the R0, R1, R2 margin definition, which R0 means that this was clear, R1 means that there was microscopic disease, and R2 indicates really that you've left disease behind. I think the aim would be to get R0 margins, but I think R1 margins, a lot of the newer papers have deemed acceptable if trying to achieve an R0 margin rate is going to leave the person with horrendous cosmetic deformities. I think R2 margins, I think if you're going to do an operation, R2 margins are to be avoided, but certainly R1 margins are, I think, acceptable, at the expense of a better cosmetic result.
I haven't seen many of those. I think we've just excised only recently. Has anybody seen lots of fibromatosis or desmoids? Anybody has seen any patients recently? Because from the images that you're showing, this can be very aggressive. It's going to the chest wall. So people end up with the huge excisions for something that is locally advanced and the locally aggressive, but it's not malignant. Is there case reports of it just invading through the chest and causing more major problems, Michael?
Yeah, I mean, certainly if you look at that Newman paper from Memorial, or if you look at the original Bonvalot group, which I think is from the Institut Curie in Paris, they described that a number of their patients who they had to do mastectomies on, they were involving, pec resections and the original kind of Halsted radical mastectomies, which are horrendously debilitating for patients. And I think that has really driven the question about is this absolutely necessary, and actually can we place these patients on active surveillance? And the answer is yes. So I think if that patient is on your MDT next week, I would be saying that unless this is particularly aggressive, or that it looks like it's growing very, very aggressively, that person should be surveyed at 6-month intervals with MRIs. And if they demonstrate significant progression, then certainly surgery is an option. But a lot of them, 80% on the basis of the systematic review by Tim Bergen et al. Will stabilize. And I think the other thing to say is that it's important, if you have a sarcoma MDT, try and put that patient through that. Get a pathologist, a dedicated sarcoma pathologist to look at it. and also to get your medical oncologist involved, because the tyrosine kinase inhibitors definitely do work as well.
I think she ended up on the sarcoma MDT. We said just take it out and let's confirm what it is. And she has relatively close margins, so I'm not sure if we're going to accept
Yeah.
it or not.
There was a number of questions on the Q&A. I don't think a diagnostic excision is unreasonable, but I think you need to be very clear with patients that a diagnostic excision does not involve completely excising this. I think sometimes a diagnostic excision is reasonable to actually prove that it is fibromatosis, because some of the pathologists find the actual diagnosis challenging to make. But I think a diagnostic excision is completely different to going in and formally doing a wide local excision or mastectomy for this. And I think that they're the operations I think that the newer guidelines want to try and avoid.
Any comments from anybody else from the Irene, you have your hand up.
Yes. I just wanted to ask Michael something about the treatment of fibromatosis. I've only seen one of them in my life, so I'm not very, very experienced in that. But I read recently about new methods like cryoablation or focused ultrasound. Have you read anything about those? Has anyone tried them?
No, and it's interesting. I was going to put up a graphic similar to the graphic that was put up during the granulomatous mastitis talk. The fact that a lot of the publications on these are case reports. Because it is so rare, the series are very, very small. And some patients or some centers have put up things where they use different techniques. Certainly, there's no strong evidence to support that. I think the active surveillance, there is strong evidence to support it, because there is, level 1 evidence that supports active surveillance, and that it has at least, the same efficacy as intervening. So I came across loads of different case reports suggesting different things, none of which have a kind of a strong evidence base. So I suppose no is the answer to that question.
And
Thank you.
is there anything on the biopsy, Michael, that will tell us, yeah, this is better to take out, or this is better just to monitor?
No, there's one very interesting paper that I actually didn't mention, because again, I thought it was probably going to open up another can of worms, but there is another one, and I think this comes back to the next generation sequencing using circulating tumor DNA to look at ctNNB levels. And if you have a high ctNNB mutation level, that can predict patients who are going to require surgery down the line. And I think going forward, that's something that we may use to predict those who might require surgery versus those who can undergo active surveillance.
And the main 3 points you mentioned about excision is young, pain, and getting larger.
Yeah, and I think it's the larger that one of the studies of the French group had said that 7 centimeters above that, if you see it at diagnosis, it's likely that they're going to require an operation at some point. So the smaller areas, 2 or 3 centimeters, are the ones where active surveillance seems to work quite well. Patients who are younger, unfortunately, tend to have more aggressive disease. And one of the studies had referenced the fact that those who came in with discomfort within that abnormality, and I think that indicates probably that there is some invasion into the pec or into the chest wall, again, indicates that those patients may have more aggressive disease and are likely to require surgical intervention.
Anybody else? Do you have any questions or comments?
I would like to tell something about, really for the desmoid tumors of breast, we don't have enough evidence, to tell the truth to our patients. My experience was limited for abdominal wall desmoid tumors with high recurrence rate. Of course, they were more just painful than breast the desmoid tumors. We don't know really the answer, and it's quite interesting. At least we have the option, to refer to sarcoma unit and to have also their suggestion about it. That's a good support as a breast surgeon for all of us here in UK. I don't know what do they do just in the rest of the world, but really we have more just publications. We need more publication about it, and we have a lot of question marks about again for the treatment of desmoid tumors. At least now we have the meta-analysis result, the most recent one, as my colleague expressed, we might avoid a lot of unnecessary operation on those cases. But the problem is most of the time, patients want to know the real evidence, and really we have the difficulties to answer their questions. I don't know, really, I found it very difficult. We don't have enough evidence.
That's the problem with the rare tumors, and that's was the idea from this, is just to see how much we have and how much we don't have. And sometimes it's just there's lots of judgment rather than evidence-based practices, unfortunately.
Yeah.
But that's beautifully summarized by Michael about things that we can do. For example, I never knew there's a medical alternative, not only surgery is an option. I never knew that you can just monitor some of those tumors. So it's an eye-opening talk with lots of great papers that were quoted. Any final comments by anybody?
Yes, I would like to tell something, Yazan. So for the IGM, just we need to have, please, separate sessions. We need to involve colleagues from Turkey, from Iran, and just, I will share our experience about the consensus meeting in Turkey, because they have published a lot of cases, and just also hopefully till then we might have, if we can manage to arrange UK, the national audit. Just I'll send the letter to basically Association Press Surgeon President, and we might have the chance to do it. But definitely, it will be very helpful and very good learning point for all of us if you can manage to organize it. And I'll be more than happy, to organize all speakers. I have a great experience because myself and Hande Köksal from Turkey, from the university, from Konya, Turkey. We will just also some Turkish colleagues, will be delighted to contribute to that meeting and to offer their, just experience. That's will
perfect.
Be helpful.
And that's perfect. We will work with lots of people from Turkey. Turkey is like second home for us now. We've been with Bahadir and Zafer and Abud and with lots of people. So hopefully that will happen. Now, since there's no other comments, one key message. So if you want to collect data on IGM, please contact Maggie. Also, you can email me, and I can make the connection with Maggie. And hopefully Maggie maybe work with Naeem in the future on this. You have more data and maybe get some more information. The next webinar is on the 3rd of February. It will be about the axilla. We're still working on the speakers and the panelists, so we'll let you know as soon as. And there'll be webinars also in March. I cannot thank you enough for being. We're going to close, Naeem.
I would like to tell something. So
Naeem, we will need to close. It's nearly 7 o'clock. So may I say something? Many thanks for all the speakers. Many thanks for all the panelists for giving up your time on a Saturday afternoon. It's nearly 7 o'clock now. We still have 400 plus people online. We had more than 600 again after all those webinars. It's great to have those numbers again. I will send you the certificates in the next few days. So for people in the States and for the South America, have a lovely day. People for Europe, have a good evening. And for people from the Middle East and the Far East, have a good night. Thank you, everyone.
Thank you.
Bye-bye. Thank you.